Thank you so much, and thank you to ISQua for the invitation to present today. I'm very happy to join everyone on this webinar today, and I am going to talk about safety and reliability during the COVID-19 crisis, which is a topic that I'm sure is top of mind, not just to people on this call or to people in the safety and quality field, but really to every clinician and patient out there right now. So hopefully this will spark some new thinking on the part of everyone on the call, and I'd be looking forward to the dialogue at the end as well. All right, let's see how I advance these slides. Hang on. There we go. So I'm going to come back to this topic of this goal of zero harm in a few slides, but one of the things that we've been really pushing at both IHI, where I was previously, and now at Press Ganey, is that we really need to commit to a goal of zero harm in healthcare. And there's been some hesitation to do that, with the sense that not everything may be preventable or so forth, but we feel like it's very important to have that aspirational goal of zero harm, and I will come back to that. We also know patient safety is a public health issue, which we've been talking about for several years now, and is clearly playing out right now in the world. And that despite progress that we've made, we've been working on patient safety for 20 years or so. We have made progress in numerous ways, and we can talk about that. But despite that progress, preventable harm remains unacceptably high, and there's significant mortality and morbidity, quality of life implications, and really is adversely affecting patients in every setting. One of the things that we've been talking about more and more has been, and we published this in this New England Journal Catalyst article that was published in January, was that we have been really trying to push to a broader definition of harm. We have started out in healthcare 20 years ago, again, when patient safety really came to the forefront, really thinking about physical harm. Now we are thinking about all the other types of harms in addition to physical harm that we should be really considering, including socio-behavioral harm, emotional and psychological harm, financial harm, and so forth. And so expanding our definition of harm, I think, is really important, and I'll talk more about this, particularly because that can really have long-term impacts on our patients, and in addition on our workforce. So one of the other ways that we really want to broaden that concept of harm is to say we need to be focused on harm to patients and also harm to the workforce. Again, very relevant today. And really, it's been a struggle to get harm to the workforce to have as high a priority as harm to patients, but we think it's a precondition that the workforce must be safe in order to deliver safe care to patients. And finally, we need to really think about harm across the entire continuum of care. Again, 20 years ago, but even over the entire 20-year period, the vast majority of work in patient safety has been done in the inpatient setting. Vast majority of research has been done in the inpatient setting. And while that's important, we need to really start thinking about the harms that could be occurring in all the diverse settings besides the hospital, including ambulatory care, including nursing homes, rehabs, and the home. So I'll sort of dive deeper into these broader definitions of harm and also how they relate to the COVID crisis that we're in today. So as I mentioned, we need to think about preventing all types of harm, and in particular, broaden the focus from physical harm to psychological, emotional, socio-behavioral harms. There was a survey that even talked about disrespect as from when patients were surveyed and asked about types of medical error that they had experienced. They cited disrespect as a form of patient-perceived medical error. This can be daunting. I mean, it's not that we have solved physical harm. So to say we need to broaden when we still have challenges with physical harm can be a bit overwhelming. But I think now is the time, as we've had a significant chunk of time to get more comfortable with trying to address physical harm, that we need to really start thinking about these other broader types of harm. And when you think about COVID and the physical and psychological or emotional harm to patients, they have really been significant parts of what we've been trying to handle on the healthcare system side. So physical harm, clearly a major concern. Making sure that we have appropriate diagnosis of COVID patients, appropriate treatment. We've been really thinking about the impact of isolation on diagnosis as well as monitoring and treatment to try to minimize physical harm. There's been rapidly evolving clinical information so that clinicians are realizing that risk of pulmonary embolism and so forth is much higher than anticipated or even known about a couple of months ago. So there's been rapidly evolving clinical information that if not understood and put into the treatment plan could lead to physical harm. Certainly end-of-life issues. And then there's been a lot of attention on harm to non-COVID patients where there could be delays in treatment, fear of coming in for treatment. We're seeing fewer heart attacks and strokes coming in, which may mean that people are staying home with those symptoms leading to physical harm as well. So there's a wide range of physical harm. And then there's the emotional, psychological harm to patients, families, and the public. Certainly there's been a lot of conversation about the impact of social isolation, both in the community, but also in hospitals, the impact of dying alone without family members, again, impact of that both on the patient and on the family. And sort of this impact of quarantine itself that can have many negative psychological effects, including post-traumatic stress, anger, confusion, et cetera. And these effects can potentially be long-lasting. So, we need to really be thinking about both of these components, physical harm and the emotional, psychological harm to patients, families, and the public as we go forward. Another piece, and we talk about this in the paper I mentioned, that it was a New England Journal of Medicine Catalyst in January, but then in January we also, I did with a colleague of mine at Brigham and Women's Hospital in Boston, a New England Journal Perspective article on the topic of safety and equity, and the fact that we need to really include inequities as a type of harm. We talk about how there's no such thing as high quality, safe care that is inequitable. And this too has been an issue that has really been rising to the forefront with the COVID crisis. I have to say, when we wrote the perspective, there hadn't been a lot of attention being placed on how safety and equity are so interlinked, which is why we wrote the piece. And now we're really seeing that play out in a number of ways. So we know that there are persistent equities in healthcare, inequities based on race, sex, language, socioeconomic factors, et cetera. There's historical roots in structural racism, other forms of systemic discrimination, and systems in healthcare have been constructed, usually unintentionally, to deliver outcomes that can vary according to factors such as patient skin color or ability to pay. A key concept is, as we start to think about this, especially with our safety lens, is inequity is a systems-based problem that requires a systematic systems-based approach. It's not about blaming individuals, it's about a systems approach, which is our, the foundations of what we've been doing for the last 20 years in patient safety. So what we've learned in patient safety for the past 20 years can help us advance equity. So we need to design systems to make them more reliable and resilient, balance system and individual accountability, recognize the role of cognitive and often subconscious biases, highlight the need for psychological safety for difficult conversations. These are not easy conversations to have when you start talking about race and racism, for example, and then avoid excessive focus on shame and blame. So when we come to COVID and inequity, we are certainly seeing large inequities, particularly in the US, but really around the world, in rates of infection, hospitalization, and mortality, certain populations being at much higher risk. Lots of proposed theories for why those populations are at much higher risk, higher rates of being essential workers, of using public transportation, higher rates of comorbidities, less access to healthcare, lack of insurance, lack of testing has come up in some articles that I've been reading as well, that certain populations have less access to testing. Globally, we are seeing predictions that there is going to be increased risk and impact on poor, underserved populations, both medically and economically. more comorbidities, poor populations lacking access to health services in normal circumstances are being left even more vulnerable during times of crisis. And again, that vulnerability to the financial implications. For each percentage point reduction in the global economy, more than 10 million people are plunged into poverty worldwide. So we need to continue to look at our data, stratify it to call attention to these issues. If we don't look, we won't find. So we need to identify where these inequities are occurring and then determine ways to reduce the inequities with a systems approach and looking at things, interventions that are social, public health, or policy related. So this is a really, I think, important time to really have the linkage between safety and inequity come to the forefront. These are all types of harms that these patients are experiencing. So this is clearly safety, and we need to bring our safety expertise to this issue. So that was patients. Broadening our focus of harm to patients to be physical and psychological, but we also need to think about preventing harm to all. Patients are not the only ones being harmed by healthcare. In the US, there are statistics pre-COVID that the likelihood of injury or illness is higher in healthcare than in construction and manufacturing or mining even, which are considered to be high-risk industries. So you're more likely to get injured in healthcare than in mining, manufacturing, or construction. There's also increasing attention to the epidemic of burnout and other types of emotional harms that plague the healthcare workforce, such as disrespect, power imbalances, implicit bias, etc. So the physical and psychological safety of the workforce is a precondition to ensuring safety for patients. The Lucian Leap Institute, which was mentioned at the start, wrote about this about 7 years ago or so, about this fact that it's really a precondition. And we've seen silos. I mean, when I ran patient safety at a large hospital, patient safety was in one silo, occupational health and employee safety was in a totally different silo with totally different methodologies, et cetera. And what we're saying is we need to bring these together and really think about them with the same types of methodologies. So, this is part of that aspect of being a precondition. Workforce safety, morale, wellness are all necessary to provide the best care possible. And so our professionals, but not just the clinicians, but really all of our staff in hospitals need support to fulfill their highest potential in order to deliver the care that we need. These are just some more statistics about the rates of physical harm. And again, this will vary country to country, but I'm guessing it's probably pretty consistent across most places, and that there are significant rates of physical harm that are occurring. And then certainly all of the different psychological or emotional harms that are also occurring and then contributing, as I mentioned earlier, to that epidemic of burnout. I think this is an interesting way to think about this as well. There's certainly stress and harm that are inherent to the role of being in healthcare and being a provider in healthcare, and we can think about what's inherent versus avoidable. And even if we think about this from our patient safety lens, the things that are inherent, we hopefully can still do things to try to minimize those and reduce the impact that they're having on our staff. But there's parts of being a doctor or a nurse or a respiratory therapist that are just stressful, as we know. And then there's parts of the job that are stressful and can cause harm. But then there's a lot of the harms, too, that we think are completely avoidable that you see there at the bottom that we need to probably start with and then also be focusing on some of these other things that, again, with the right supports, could have far less impact than they are currently having now. So in the current COVID crisis, we've been thinking a lot about caregiver physical and emotional safety. And, it's probably the first time I've seen this. I mean, with Ebola, we certainly talked about this, but probably more so on the physical harm side. But really that both physical and emotional safety are getting a lot of attention from healthcare systems, I think is a positive in the sense that I think this has been an area that hasn't gotten the attention it's needed, and I'm hoping that this will now start to get attention in this current situation and beyond. So certainly physical harm, we have had issues with lack of personal protective equipment, the risks of infection and illness and death on the part of people working in hospitals. And then there's been psychological, emotional harm, stress, burnout, fears for self and family, moral distress, especially in places where there's been lack of ventilators or beds, financial distress to caregivers who are in many places experiencing pay cuts or furloughs. And there's much work underway to try to address the physical PPE challenges with increased supply, reduced number of room entries to minimize PPE needs, lots of work to work on staffing and bed availability and all of those things to try to address the physical challenges. Actually, one other psychological, emotional harm that we've been seeing too is often the nurses and physicians are being put into situations where they are not comfortable. So someone who is usually an ambulatory nurse might be in an inpatient setting. Someone who's a psychiatrist now may be acting more as a medical physician on a ward because of some of those staffing challenges. So that's another area that we've been writing about and seeing potential impact as well. So a lot of work underway to address the physical challenges, and importantly, I've been encouraged to see that there has been significant focus on the psychological, emotional harm component as well. And as I mentioned, far more than we've seen in the past, even though, as I showed, these are not new issues given the burnout baseline that we have right now. So examples of interventions organizations have been putting in place during COVID around caregiver emotional safety in particular. We've seen examples of having physical spaces on site where caregivers can have downtime, resilience lounges, they're calling them, physical spaces for quiet time, just places where people can get food and drinks and so forth, physical space to support protection of the family, having caregivers staying at hotels or recreational vehicles. I'm trying to think of, it's basically a camper, dorm housing. They've been having a focus on exercise or meditation that can be accessed for free when caregivers have a little time off. Food, coordinating with the community to deliver meals to healthcare workers and healthcare worker families so they don't have to go to the market or cook for themselves. And then lots of emotional support, whether it's a healthcare coach to reach out, virtual telemedicine with behavioral health specialists, buddy programs, particularly in that instance I talked about where a inexperienced person may be being placed in a situation where they're not comfortable having them paired with a buddy. Caregiver going home checklist. This is something that I saw out of a system in the UK where there's a going home checklist to support decompression prior to leaving. A lot of overhead broadcasting of messaging. There's been broadcasting when patients are discharged or taken off ventilators as well for that positive feedback. Texting managers on patients discharged, texting thank yous, and so on. I mean, the list really goes on, and I've been very impressed with how rapidly some of these things have been put into place to really focus on emotional safety and I think also really trying to reduce the stigma of some of these things as well, particularly for physicians who often are not very good at asking for help, but even for nurses and others to try to take away the stigma that says you need to just be strong and tough, but to say that, it's okay to ask for help and take help and need help. And I think that's an important cultural shift, I hope, that will continue. So, ultimately, as we think about safety as we go forward, what my goal is, and I've seen some organizations moving to this even again pre-COVID, is that we should be really thinking about harm. And that includes patient and workforce harm, and break down those silos as I described earlier, where these are in two separate worlds. Thinking about dashboards and other things, any dashboard always having patient-related harm and workforce-related harm side by side. This is a slide from Cincinnati Children's where they talk about any time they're presenting harm data. They use this pyramid of harm, and on the left would be the patient harms, and on the right would be workforce harms in these various categories, and that goes all the way up to the level of the board of directors, because we know often that boards are not even seeing data on workforce harm. And so the idea here is that these things need to be worked on together and talked about jointly, et cetera. So my hope is that this doesn't become, that this kind of exemplar that I'm showing for you becomes more of the norm as we go forward. Okay, and then last part of the harm piece is we need to think about preventing harm across the entire continuum of care. So hospitalized patients may be at greatest risk of harm, but harm occurs in all settings. I started out my career as a safety researcher, and my area of interest was patient safety in the primary care setting and ambulatory settings. And there was really no attention on that 20 years ago. And over time, it has started to grow. Still, as I mentioned earlier, far more work is done in the inpatient setting, and I think it's really the time to expand to think about the entire continuum. In the US, the vast majority of care is given outside of hospitals. If you think about when I say all of these settings, it's a very diverse range of settings, including primary care, specialty care, ambulatory surgery, dialysis, nursing homes, rehabs, urgent care. I mean, you name it. There are so many different types of settings, so it makes the task overwhelming in some ways, because we know that the specific types of harm in each of these settings are going to be different. The other piece that we've had a lot of attention on in the last few years too is safety in the home, because more and more patients are getting care at home with services and other things, and thinking about the risks there is an important area to explore as well. And because the emotional and psychological harm is really spread out across all of these settings, the overall burden is likely to be much greater outside the hospital, especially given the volume. So in 2018, there was a report from the OECD that talked about ambulatory safety, and that safety lapses in primary and ambulatory care are common. Many are avoidable. What the report said was up to 80% of harm in primary and ambulatory settings can be avoided. Half of the global disease burden arising from patient harm originates in primary and ambulatory care. So we are missing a significant half of the potential contributors if we're only focusing on the inpatient setting. And the financial and economic costs of safety lapses are quite high. This is an infographic from the Agency for Healthcare Research and Quality in the US that talks about some of the rates of harms in or errors in US studies. And so things like diagnostic error, medication errors, and adverse drug events, et cetera, occurring at high rates in the ambulatory settings in the US. So when we come back to COVID, we are really seeing this play out, that the risks are absolutely spread out across the entire care continuum. And we've also found that we probably were far less prepared to handle it in many of these outpatient settings compared to inpatient, in terms of resources, in terms of having quality and safety infrastructures in place, et cetera. So we've been thinking about first responders and how do we protect that population. Nursing homes has turned out to be a very high-risk setting, and there's been difficulties handling social distancing, staffing, PPE needs, et cetera, given the way nursing homes are organized. Many deaths, approximately 20% of US deaths currently is what the number is. In my state, in Massachusetts, it's over 50% of the deaths are in nursing homes. And I saw statistics from Canada and Europe that it's around 50% as well. So many of the deaths occurring in this nursing home setting. And then we certainly are seeing impacts in ambulatory with canceling of elective surgeries, delays in appointments, delays in cancer treatments. Positive of the swift shift to telemedicine as well, but significant impact there as well, and the need to really make sure there's not unintended consequences. So all of these changes were appropriate responses to trying to maximize social distancing and minimize the impact of COVID. But now we are going to really need to think about how do we minimize the unintended consequences of those shifts so that we don't have delays in diagnosis or treatment, et cetera, with those changes as we go forward. Safety at home during COVID has been a really important issue. A lot of patients who have visiting nursing or home health aides or other caregivers coming into the home who now maybe can't come into the home, don't have PPE available to come in safely, has been a real challenge. And really, I think COVID has helped to raise awareness that patient and workforce safety interventions must span the whole continuum, all settings, and all kinds of caregivers. So, as we kind of think about the impacts that COVID is having and the implications on safety, I think it's important to really think about how safety needs to be our core value. We've often talked about safety as a priority. We need to make it a priority to improve patient safety, but priorities are temporary. They can shift. And, it's been a priority during COVID now. There's been a lot of attention. I would say one of the concerns that we've had over the last 4 or 5 years has been that there's been less attention on safety. There's been a bit of complacency. We've been working on it for 20 years. We've made some progress. It's time to maybe move on to some other things. We're doing better. There has been a complacency, and there's been a lot of work by leaders in safety to think about how do we get past this complacency and accelerate our progress again. That was sort of the thinking between the National Patient Safety Foundation and the Institute for Healthcare Improvement when we decided to merge. There's this complacency. By merging, we'll be stronger. Let's try to drive out the complacency and build urgency again. So now we're seeing that urgency. We're seeing safety as a priority, but we need to move from prioritizing it to making it a core value, because priorities are temporary. They can shift. Whereas if we make it a core value, it is just the way we do things here going forward. And so it can become really a value that defines and reinforces our culture and drives our work going forward. And then coming back to this idea of zero harm, we need to aspire to that goal of zero harm. There's a famous quote: "Perfection is not attainable, but if we chase perfection, we can catch excellence." This is a coach in the U.S. In American football, not football of the rest of the world. And this is exactly what's occurring in ambitious forward-looking health systems today. Forward-looking health systems that are ambitious around safety have set a goal of zero harm, and by chasing zero, they are achieving excellence. And that's, I think, what we need to strive for across all of healthcare. So with that, I want to shift a little bit in the last few minutes. I talked about how the values can affect our culture. And I want to talk a little bit about culture and high reliability also as foundational components as we think about how we're going to advance safety going forward. Over the last 20 years, again, we've talked a lot about the need for a culture of safety and the need for implementing systems that are highly reliable with high reliability principles. And those concepts, I think, are particularly relevant, again, during COVID and as we move forward with how we think about safety in the future. So we need to ensure that leaders establish and sustain a safety culture. You all, I'm sure, are quite familiar with the concept of what a safety culture is. It's very foundational to achieving total system safety, and it's a culture where professionals are accountable for unprofessional conduct but not punished for human mistakes. Errors are identified and mitigated proactively, and there's strong feedback loops to enable learning from previous errors. And when you think about the learning system concept, that comes in here. This is data, again, from the US, but I'm guessing it's probably pretty similar across much of the world. Even in 2018, so that's, almost 20 years after To Err is Human, on a national culture survey that can be benchmarked, 47% of respondents indicated that they have a non-punitive response to error, which means over half of people still feel they are working in punitive environments. And so that's a bit disheartening, given that we've been working on culture for quite some time. Though, you know, you can also think of glass half full, because I am sure 15 or 20 years ago that number would have been far higher, and culture can be very hard to change. So it's probably not surprising that we still have a lot of work to do on that front. So this is really a leadership imperative that leadership needs to drive this culture throughout the organization, and it really requires dedication of leaders to the principles and behaviors present in cultures of safety. So, you know, when we think about safety culture transformation, it includes many of the things that I've already been talking about in terms of adopting this goal of zero harm and that clear messaging on safety, measuring harm and making harm visible, having a fair and just culture, having daily check-ins for safety, such as huddles. And this framework for safety culture transformation came out of the organization where I work now, which is their structure for driving culture change. Another one that I want to highlight for you came out of the Institute for Healthcare Improvement, leading a culture of safety, a blueprint for success. This also has very similar concepts to the one I just showed you, but turned into 6 domains that really talk about how leaders need to set this vision of safety and zero harm, ensure that there is trust, respect, and inclusion in the organization. If there's a board, have the board be fully engaged in patient safety and workforce safety. There needs to be leadership development, so leaders at all levels of the organization can advance this culture. It's great if the CEO and board and C-suite, whoever they might be, are driving culture, but if the middle managers and other leaders in the organization don't have the skills to also drive that culture, it's going to be a problem. So really making sure leaders across the organization are able to create this culture. Having a just culture, very important, and then setting clear behavioral expectations. So what does the organization expect in terms of teamwork, communication, in terms of how you're handling disruptive behaviors or bullying behaviors, et cetera, and having consequences for those behaviors. And consequences that are uniform regardless of stature or status of the person who's doing them. So those are all components that we think leaders need to focus on to advance a culture of safety. And in this document, there are strategies and tactics underneath each of these, because one of the challenges, I think, has been we've talked a lot about let's create a culture of safety, but leaders haven't necessarily known how. They've said, yeah, sure, that makes sense, let's do it, but how? What is the how? And so if people are interested in digging deeper, this particular document has quite a few strategies and tactics that can be implemented to advance progress in each of these 6 domains. So in addition to the cultural work, there's been a lot of attention, as everyone knows, about trying to create high reliability organizations that can operate under very trying conditions all the time and yet manage to have fewer than their fair share of accidents. And so, you know, it's been interesting during COVID, as I've been talking to organizations around the US, and organizations who have really committed to trying to become high reliability organizations have been saying that it has made responding to COVID not that it's been easy, but it has been far easier because they had a lot of these high reliability principles, concepts, skills, behaviors, et cetera, in place in their organization. And that made it easier for them to have a response to the COVID crisis. And, you know, I think we'll have to see how that plays out over the next period of time. I'm sure there'll be studies and other things to try to understand who was able to respond well, who wasn't, what were the attributes that allowed that to happen. But we're hearing anecdotally, at least from the people who have been really forward-thinking and high reliability, that they have found it to be incredibly helpful in their response. So here are 8 fundamentals for HRO transformation, tying into the cultural piece, of course. So setting the strategy and vision, having measurement and control loops, having leadership skills that I'll talk about in a little bit, fair and just culture, daily safety briefings, foundational communication processes, and universal skills for all around relationship building, reliability skills, and process improvement. And so when you think about COVID and sort of these concepts of safety culture and reliability, this concept of needing a compelling vision for safety and the leadership skills, that has been an incredibly important piece of the COVID response. So, organizations have really focused on having visible leadership with visible communications about safety, clear communications. That's actually been one of the things that we've heard about the most is many organizations have felt that the communication has been critical and making sure it is structured and organized and not confusing has been a really important piece. Crisis management structures, certainly an important piece of how leaders are trying to address the situation. And then, we were actually wondering if people would do daily huddles and rounding, especially with worries about PPE and other things. And we're finding many organizations are saying, even if it's through virtual technology, they are absolutely doing their daily huddles and rounding because they need to have that visibility with their staff and also be keeping their finger on the pulse of what the staff are experiencing. So those have been some of the culture and reliability skills that leaders have been using. On the just culture front, certainly having a just culture during COVID is really critical. We've unfortunately been hearing examples in both directions, however, where so in some organizations, people are speaking up about concerns and they're being heard and response has been very positive. And in some organizations, people have been speaking up and sometimes often through the public or social media or other things, but then there's been punitive responses. And so I think we still have a lot of work to really make sure we have just culture implemented robustly in our organizations. Behavioral expectations and universal skills. So really ensuring that staff, particularly those in new roles, but really all staff, feel comfortable speaking up, feel comfortable reporting problems and challenges, tying back to that just culture concept. Again, having clear communication methods between staff. Staff are, working together who've never worked together, making sure that they have ways to communicate well with each other around patient care, et cetera. There's been a real focus on trying to create trust, respect, and inclusion, and build, for leadership to have the trust of their workforce has been critical. And many of the things I described earlier has really helped to build or decay trust in leadership, depending on how some of these things have been handled. So the last piece I'll say, so a core principle of safety culture, of reliability, especially when we talk about collecting and sharing data, et cetera, is transparency. So I just want to end with a minute on transparency before I wrap up. And we did some work at the Lucian Leap Institute a few years ago about how transparency is such a critical component to safety and safety culture. And we talked about 4 interrelated domains of transparency. So there's transparency between clinicians and patients, for example, shared decision-making or disclosure after a medical error. There's transparency among clinicians. So if you think about peer review or just sharing case discussions at a case conference, transparency among organizations. So if there's regional collaboratives, we have in the US patient safety organizations, but if there's mechanisms in your region where across institutions there can be sharing, and then sharing with the public. So we've had public reporting of safety data on various websites over the past several years, but really how do we effectively share data with the public? So those are the 4 domains of transparency. And I've found it really interesting that all 4 of those have also been front and center during COVID. So we have transparency with patients and families. Certainly there's been a lot of transparency around the risks and benefits of treatment. There's been transparency even around the pandemic with the public. Well, I'll come to the public in a moment, but with patients and families, there's been discussions about shared decision-making, risks, benefits, end of life, et cetera, that have been going on. Organizations have been publicly posting case rates and death rates and so forth, also very visibly. There's been transparency with colleagues within an institution. So lots of examples of collaboration and teamwork within organizations to optimize best practices, protocols, PPE, donning and doffing, et cetera, transparently sharing data about staffing, about ventilators, about census, about discharges, et cetera. The one that I find most remarkable maybe has been the transparency between organizations, which, we've been talking about for many years, that we need to have better sharing across organizations for learning and improvement. So we're not working in silos and reinventing wheels in every organization. And we have seen globally, really, I highlight a couple of things here from the US, but also globally, that there have been regional, national, global collaboratives where people are learning and sharing from each other, sharing protocols. I'm on a I'll walk through these. So like in Boston, where I live, there was a story on the radio about how the Boston CEOs have a call every morning to talk about how they're addressing the volumes and the PPE, and they're working together on all of that. And I'll tell you, those CEOs normally don't work together. They compete with each other. Houston has a similar story in the US. National collaboratives, we've seen networks of infectious disease doctors or networks of hospitals who are rapidly learning and sharing. The World Health Organization has a global listserv. IHI has a global mechanism also for learning and sharing. And so it's been, I think, really encouraging to see how the transparency between organizations has really blossomed, I think, during COVID. And then finally, there has been transparency with the public around flattening the curve, social distancing, public health in general, the data. Lately, we've been seeing a lot of public health messaging here in the US about trying to reduce fears so people will return to healthcare, trying to get at that issue of people with heart attacks and strokes, for example, who may not be coming in. So there's been public health messaging there. So I just thought that was worth calling out, that some of these strides in transparency have been really remarkable. So as we think about, and I probably shouldn't even use the term post-COVID anymore, because we know that COVID is here for a while, but as we get to the new normal of living with COVID, I think there's a real opportunity for us in healthcare and in safety to try to learn from positives. So we take a little bit of a safety two lens, like what has gone well and what can we try to grow and expand as we go forward, because it has been a really difficult time. We can focus a lot on the things that maybe haven't gone well, but there have been some things that have gone well, and I think it's worth spending a moment to think about that. We have seen some really incredible examples of leadership and culture, as I've described, around the visibility and communication and rounding and teamwork. There's been a really intense focus on caring for caregivers, both physically and emotionally, which has been really a new focus that I'm hoping will continue. We need to figure out how to make it continue. There has been a lot of focus on patient and family connection, especially given the social isolation, et cetera, and lots of examples of using technology to do this, but also earlier end-of-life conversations, palliative care engagement earlier, et cetera, which has been really focused on helping families during this time. Transparency, as I've talked about, also the attention and focus that is being shifted to really think about safety across the entire care continuum, and just the rapid pace of change and adoption that we've seen on certain things. One of the things that we struggle with, I know, in safety and quality is, things take a long time to change, and we've seen really amazing pace of change here. And not that I think we want to be continuing at this pace forever, but hopefully we can find some sort of happy medium that is faster than we've been in terms of our pace of change. And so we can try to learn from some of these examples of rapid change. And I'm sure there's many others. Those were just the ones that I came to as I was thinking this through. So to conclude, we really must lead with safety in all that we do, in quality, safety, patient experience, et cetera. We must lead with safety with this goal of zero harm. High reliability is really the chassis or the foundation for getting there, along with the safety culture work. In safety, if you think about safety writ large, much has improved since To Err Is Human, but we have a long way to go. We need to think about safety as a core value, as a public health issue. We need to consider these broader definitions of harm that I spent a lot of time walking us through, and culture and reliability are the key drivers to getting there. And COVID-19 has only re-emphasized the importance of all of these safety priorities or safety components, such as culture and reliability. It's really emphasized that organizations who are further along on the safety and reliability journey may be better equipped to handle this kind of crisis. And we need to continue this focus on safety once the crisis slows. We don't want to lose the focus. And we need to ensure that some of these new efforts, some of those positives that I highlighted, continue far beyond. So I want to thank you all for your attention. I will wrap up at this point, which I went a little longer than I was expecting, but hopefully that's okay. And I think there's still some time for questions.
Hi, Tejal. Just to say thank you so much for joining us today. Looking at the comment box as we were going through the presentation, nothing but glowing comments. Everyone really enjoyed that. And me in particular, as an American football fan, I like the Vince Lombardi reference as well. So that was good to see. So we're going to go straight into the questions here. Our first one is from Jai Kaur, who, by the way, gets special mention since he's joining from Australia, which is no doubt is early AM at the moment. He said, high impact incidents such as sentinel events with significant impact on patient safety draw attention immediately. I don't understand why we have to wait for something major to happen to bring a change. Small issues get lost in the system until they result in huge loss or adverse events. So I think that's kind of more of a general comment, I guess. I don't know if you want to comment on that.
Yeah, and I think it's a really important comment. I mean, as we think about how we build our learning systems in our organizations, I think it's really important to think about, how we are using information from the smaller events, particularly the near misses, but even the low harm events. Because some of the work that we've done, especially around root cause analysis in my past work at the National Patient Safety Foundation, was to say we need to really not just do deep dives on cases of high harm and actually have more of a prioritization matrix that thinks about severity and potential severity and also frequency of occurrence. Because, if we spend a lot of hours focusing on a high harm event that is literally going to happen once in a lifetime, those are resources that instead probably should be spent on cases that have maybe a high potential severity. No harm has happened yet, but boy, it really could, and are happening all the time or happening, every week. So thinking about shifting how organizations look at their events to think about both frequency and severity or potential severity, I think is a really important change that we need to push forward. And if anyone's interested in thinking more about that, there's a document called RCA Squared, Root Cause Analysis Squared, that is available now at the Institute for Healthcare Improvement. That's freely available. That really talks about this severity and frequency type of assessment.
Excellent, thanks, Joe. Our next question from Patricia. Should we focus on harm or excellence? Is focus on learning from everyday work where most of the things go right and resilience of our systems a better way forward?
So I think the way I've looked at this is a both and. I do think we've spent a lot of time thinking about when things go wrong. And so I think it's really important to and so that's the safety 1 versus the safety 2 thinking. And I think we need to do both. And I do think we've been focused more on the when things go wrong. So shifting attention to the when things go right piece is an important thing that we need to grow and expand on. That's why I tried to end with some of that piece as well. And even thinking about it with some of the things that we currently are actively doing in the what goes wrong space, like root cause analysis, you could think about, actually, can we do root cause analysis when a case goes right? When something that was highly complicated and you actually are sort of surprised that it went well, that would be a great case to do a root cause analysis to understand, well, what did go right here and what can we learn from and expand? So I guess my answer would be, let's do both.
That's great. Thank you. Our next question from Peter. He said, great overview. Can we expect safety within the current construct of healthcare provision that has not been designed for safety, such as the way we train staff and integrate services, or do we need a total redesign?
I think many of us would love to have the ability to do a total redesign. Because I agree with you, it hasn't been it hasn't been systematically in the way we've designed things currently. I think it's one of those. Can you fix the plane while flying the plane? I mean, I don't know that we have the ability to do that. Stop everything and totally redesign. So I think we have to try to do it as we're continuing with the processes that we have and try to pick off the high opportunity areas that we can, but I'm not sure that we can just, pause and do that total redesign. However, a crisis is an opportunity, right? And I think that the opportunities to do more of these total redesigns is now more than ever. Because I'll tell you, I never thought that we would shift from essentially almost no telemedicine to all telemedicine in the course of a week in U.S. healthcare. Like, that just is shocking. And that is going to end up, I think, with a really significant, maybe not total, but a really significant redesign of how outpatient care is happening. And so, I think we have to take the opportunities when we can get them to do as much of that significant redesign as we can.
Excellent. Thanks, Tejal. Folks, we've got about 5 minutes left, so I'm just going to ask you, if you wouldn't mind, in the Q&A box to use the thumbs up icon to upvote any questions that you prefer to see answered before we finish up. Our next question is from Ilya. Is there any change in the rates of adverse events under the COVID-19 epidemic relative to the change of elective surgery practice and lower level of event-prone procedures?
I don't know the answer to that yet. It's been so quick. I mean, I'm guessing that safety officers in hospitals may be starting to see some of that shift. If there is a shift, though, I think we might have, fewer surgical, but more medical. I mean, I don't know that we're going to see a reduction in rates of events. And I think also with the increased focus on some of the challenges that have been going on, you might see far more reporting, or you might see staff who are just so busy and stressed that they aren't reporting on the reporting systems because they don't even have the time. So I'm not sure which way it's going to go, but I think our colleagues who are safety officers in hospitals and health systems are going to be starting to see those trends relatively quickly. One of the things we have in the US are these things called patient safety organizations, where people send in their safety event reports so we can do overall tracking and trending. And where I currently work, we have one of those. And so that's something I want to be looking at over the next couple of months to try to see what those trends are, but I don't have the answer yet.
Okay, excellent. Thanks, Tejal. Our next question from Salima, who said, thank you for the excellent presentation. Please elaborate on presenting staff harm events. Has there been an impact on presenting these to the board? What is the correlation to patient harm events?
So we've talked a lot about in patient safety how the board needs to have more oversight and governance of quality and safety in general. And one of the ways to do that is to make sure the board is really seeing harm events. And many organizations have started by sharing patient harm events, but not all. It's still not universal. We did a survey a few years ago and found that only about a third of boards were even looking at staff harm events. And so that's been one of the things we've been really advocating for, is to say you have to share that as well. Because really, if the board has focus and attention on an issue, that issue gets then focused on by the CEO and by the organization. So the board has a lot of leverage and power over what an organization thinks is important. And so I think the impact of presenting these staff harm events to the board can be very powerful, especially in a context where most of them aren't seeing any of this information, and not to mention the information about the financial impacts of staff harm, it's actually an easier case to present the financial impact and ROI numbers around staff harm than patient harm. Because you have lost days from work and turnover and other things that are real costs to an organization. And so I think there can actually be quite a lot of impact of having that information get to the board level.
Excellent. Thank you, Tejal. Our next question from Ian, who said, I agree there's a focus away from safety in its own entity and there is a move to patient outcomes. What people forget is safety is intrinsic in outcomes, and if harm has occurred, it is a detriment to the patient outcome. My question is, how can we ensure this is all encompassing and not just focused on typical normal harms, such as those measured in the UK as part of GIRFT, such as surgical site infection rates?
Yeah, I mean, I think safety measurement has really been a huge challenge, and we've tended to measure the things we can measure as opposed to maybe the things we should be measuring. And I've definitely seen organizations who will say, oh, our central line infection rates and our surgical site rates are pretty good, so check, we're good on safety, which is such a small component of the overall breadth of the safety issues that can occur. So I think, as we think about dashboards that organizations are looking at, we need to really make sure they're seeing a much broader picture of safety and have it actually be, culture, structure, process, outcome measures, not only outcome measures, because the outcome measures can be so limited. If there's interest in this particular area, I will mention, I can share afterwards as well, if you remind me, is the Lucian Leap Institute, again, just in December, released a report on kind of how do we reboot our thinking on safety measurement and get to a kind of a much better place on safety measurement where we're not focused on a limited set of reactive measures, but really thinking about proactive measures as well. So how do we measure risk rather than harm? Because if we measure the risk, we could intervene and prevent the harm. How do we think about the entire care continuum? How do we bring in the patient voice? All of these kinds of things. So that's a report that came out in December that is really has some guiding principles around how we can think about shifting the way we measure safety.
Okay, brilliant. Thank you. We'll include that in the follow-up email that goes out to everyone so they can check it out. I'm conscious of the time now. We're just on the hour. However, I think we have a very important question from Laurie, which will be a fitting way to finish up. They've asked, how can a focus on the foundational issues of safety, culture, and high reliability in the midst of a crisis? I've heard people say we don't have time to think about those sort of things right now.
I think what we're seeing is organizations that are responding to the crisis are absolutely thinking about these issues and putting focus on them, because that's the only way you're going to be able to respond to this kind of crisis. I mean, the organizations that are really thinking about having the leadership visibility, the trust, the daily rounding, the huddles, all of those things that are components of safety and culture and high reliability, those are the ones that are, having a really robust response to this crisis, and I just don't see how you could possibly have an appropriate response if you don't have those things. So I think leaders who understand crisis management understand how these things are foundational to it.